Hello everybody, my name is James and I welcome you to this educational lecture on immune thrombocytopenia, a condition that is characterized by a low platelet count due to the body's immune system attacking its own platelets. So in this video, we will explore the causes, symptoms, diagnosis, as well as the treatment options. But kindly hit the subscribe button and let's get started. Alright, so let's take a look at some brief pathophysiology of immune thrombocytopenic purpura, which I would be referring to as ITP. So generally, the spleen plays a crucial role in both the production of antibodies and the clearance of immunoglobulin G-coated platelets, which actually highlights its importance in the immune system. So we have immunoglobulin G, and if you recall, immunoglobulin G has an Fc portion, right? Immunoglobulin G binds to specific glycoproteins on the surface of the platelet membrane, and it forms something we call platelet-coated antibodies, right? Now, the macrophages in the spleen utilizes its Fc receptors. As you can see right there, this is the Fc receptor of the macrophages, and they utilize that to remove the platelet-coated antibodies through phagocytosis. So the spleen is actually a primary location for the destruction of the platelet-coated antibodies. It's important to also note that the destruction may also occur additionally in other parts of the reticular endothelial system, such as the liver. For example, platelets that undergoes desialylation are cleared by the liver through certain receptors called Ashwell-Morel receptors. Desialylation is just a removal of sialic acid from the glycoproteins on the surface of the platelets, and such platelets are removed by the liver, for example. So this generally would lead to a shortened platelet lifespan in ITP. Platelets normally have a lifespan of about 7 to 10 days, but in ITP, they may be removed sometimes within hours to say a day. There is also the interaction between the splenic macrophages and CD4 cells. Now, CD4 cells can also stimulate B lymphocytes that will subsequently lead to the formation of plasma cells. And plasma cells contributes to the production of these platelet autoantibodies that ultimately attacks the platelets. So you can see that there is a platelet destruction. And the destruction can also occur in the peripheral blood as well. So this is the area here where corticosteroids and IV immunoglobulin may lead to low platelet destruction. Now, in parallel, we are also looking at the bone marrow right there. And this is important because the bone marrow would actually try to compensate for platelet destruction by ramping up production with megakaryocytes. So megakaryocytes are sort of a young thrombocytes. So these megakaryocytes should somehow mature into platelets. And there is actually a problem or an impaired thrombopoiesis with a compensatory failure of thrombopoietin to actually rise. So we see that thrombopoietin is declined in immune thrombocytopenic purpura. And not only the destruction that occurs, but there is also an impairment in the proliferation of megakaryocytes into matured platelets. So therapeutically, we can target this part with corticosteroids as well as IV immunoglobulins, but we can also target this side of the equation with, say, thrombopoietin receptor agonists. Now, eventually, the impaired thrombopoiesis right there would lead to thrombocytopenia. And depending on the severity of thrombocytopenia, there can be hemorrhagic episodes and, of course, a purpuric rash. All right, so another important thing to note is that the platelet-coated antibodies can actually invite complement fixation and this can enhance opsonization, and of course, there's going to be more phagocytosis by the macrophages in the spleen. I wanted to add up that there is an interaction between CD4 cells and macrophages, as well as CD4 cells and B lymphocytes. In between these cells, there are CD receptors, for example, CD154, CD20, CD28, CD40. It's much more complex than that. But if we target these receptors, certainly we can somehow decrease the production of these platelet antibodies that serves to destroy the platelets. In chronic immune thrombocytopenic purpura, there is a T cell dysregulation through the induction of cytotoxic CD8 cells that serves to destroy the platelets independent of antibodies. Clinical manifestation. ITP may present with a distinctive pattern of generalized superficial bleeding in the form of a purpuric rash, such as petechiae, ecchymosis in the form of a cutaneous or a mucosal bleeding, typically emerging after a viral infection in an otherwise healthy individual. Purpuric rash may present alongside symptoms like epistaxis, menorrhagia, oral bleeding, hematuria, or a gastrointestinal bleeding, and disease severity or hemorrhagic episodes usually correlates with the degree of thrombocytopenia. Notably, while ITP typically resolves spontaneously in children without a long-term effect, it is crucial to recognize that the spleen is not enlarged in primary ITP. If the onset of ITP in the pediatric contingent is usually acute, then chronic ITP often affects adults and has an insidious onset and evolves rather into an acute ITP. Petechia is a pinpoint non-blanching spot less than 2 mm. Purpura is non-blanching, greater than 3 mm, and may be palpable. Ecchymosis, often referred to as a bruise, is usually greater than 1 centimeter. It's important to note that hemorrhagic episodes correlate well with the level of platelets, and generally symptoms are absent if platelet levels are greater than 50,000 cells per microliter. Easy bruisability is seen if platelets are within 20,000 to 50,000 cells per microliter, and in such cases, spontaneous bleeding may be absent, but when platelet levels are less than 20,000 cells per microliter, there is a risk for spontaneous bleeding. Immune thrombocytopenia progresses through clinical phases that includes the newly diagnosed. Usually, this is within 3 months of diagnosis. Here, it may get resolved or progress to a persistent ITP that lasts between 3 to 12 months. Chronic ITP occurs when symptoms goes beyond 12 months. In some cases, patients may develop a refractory ITP where symptoms persist even after splenectomy. Understanding the progression of ITP can help in tailoring treatment approaches and managing the condition effectively. Diagnosis. So ITP is a diagnosis of exclusion. You would like to assess for the platelet levels. Thrombocytopenia is defined as platelet level count less than 150,000 cells per microliter. Sometimes this may be as less as 10,000 cells per microliter. Antiplatelet antibodies are not useful, hence not recommended because of its poor specificity. Bleeding time may be increased. Peripheral blood smear or bone marrow smear would show an increased megakaryocytes, which is a sign of platelet destruction. However, this can also be normal. Autoimmune hemolytic anemia can coexist with ITP. So I know you're saying you're going to ask for what? The Coombs test. And this will be positive. On a peripheral blood smear for autoimmune hemolytic anemia, you would also see a microspherocyte. In which other anemia would you see microspherocytes? Of course, you're saying hereditary spherocytosis. Now, depending on the clinical suspicion, you may also like to ask for vitamin B12 as well as folate levels, as this can also lead to thrombocytopenia. Paroxysmal nocturnal hemoglobin urea must also be excluded. Typically, clotting profile remains normal in primary ITP. As we said, this is a diagnosis of exclusion, And so you would need to exclude lupus as well as HIV, hepatitis, among other viruses. Chronic lymphocytic leukemia and lymphoma can also be associated with ITP. You need to assess the drug history for any drug-induced thrombocytopenia. Treatment. So it is not recommended to treat a mild ITP. Corticosteroids are considered first line of therapy with a noticeable response expected within 3 weeks. Again, in the management of ITP, intravenous immunoglobulin emerges also as a crucial option, particularly when swift platelet count elevation is imperative. It is also considered first line due to its rapid replenishment compared to steroids. However, its effects are short lived and sometimes there is the need for repeated administrations for a sustained efficacy. Splenectomy. This is very important and it is often reserved for cases where first line treatments have been unsuccessful in managing ITP. It is considered the treatment of choice in adults with persistent ITP. Now, before undergoing splenectomy, individuals may be required to have vaccinations such as a pneumococcal vaccine to reduce the risk of infections. Treatment of ITP also includes the use of thrombopoietin to stimulate platelet production, particularly in cases of chronic ITP, as you don't want patients to progress to a refractory stage. Thrombopoietin also has a response rate of about 80%. Rituximab has also been used, an IV role immunoglobulin for rhesus positive patients who have an HB of greater than 8 gram per deciliter is also used sometimes. This has a risk for hemolysis, and so you would like to be careful. Now, azathioprine, vincristine have also been used for chronic ITP. Regarding biologics, there are agents that are still undergoing clinical phase trials, and they may have their role to play in the treatment of ITP in the future. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.